That's a good question.
I probably did do that. I probably did do that the year that I did one for copy.
We good? All right. Good afternoon, everybody. Thanks for coming to my CE on this Thursday afternoon. My name is Morgan Thomas. I'm one of the PGY1 residents here. And today we're going to be discussing acute HFrEF or heart failure with reduced ejection fraction hospitalizations and what should we do with all of their GDMT. Before we start this presentation, I'd like to mention that I have no disclosures that should impact the integrity of this presentation. By the end of this presentation, it's my goal that we will have reviewed the clinical presentation and staging utilized to classify heart failure. You'll be able to list precipitating factors for acute decompensated heart failure that may lead to hospital admission. You can identify clinical situations in which the withdrawal of chronic beta blocker therapy might be appropriate. You can describe an ideal candidate for which an SGLT2 should be initiated during hospitalization for acute decompensated heart failure. And you can develop an appropriate discharge plan to optimize the patient after being hospitalized for acute decompensated heart failure. This here is a slide just for completeness sake that goes through some of the abbreviations and definitions that will be used throughout this presentation. So it's estimated that heart failure affects approximately 64 million people worldwide. From 2013 to 2017, there was an estimated 20% increase in heart failure hospitalizations. Some risk factors include hypertension, obesity, patients with prediabetes or diabetes, and atherosclerotic cardiovascular disease. Some potential causes include ischemic heart disease, myocardial infarctions, valvular heart disease, chemotherapy or other cardiotoxic medications, rheumatologic or autoimmune diseases, and substance abuse. Moving into the clinical presentation, patients with heart failure have a dynamic clinical syndrome with symptoms that are caused by an impaired ventricular filling of blood. These patients may present with symptoms such as dyspnea, fatigue, chest pain, and fluid retention. And it can be classified further once they have a diagnosis of heart failure based on symptoms and ejection fraction. So this brings us to our first knowledge assessment question of the day. Here we have BH, who is a 54-year-old female with heart failure, who recently had an echo that had a left ventricle ejection fraction of 37%. Currently, her physical activity is markedly limited due to shortness of breath. However, she's comfortable at rest. So according to our ACC or AHA guidelines and New York Heart Association classifications, how would you stage BH's heart failure? Is it A, heart failure with reduced ejection fraction with an NYHA class of 2, heart failure with ejection fraction, NYHA class of 3, heart failure with preserved ejection fraction with the NYHA class of 4, heart failure with improved ejection fraction, NYHA class of 3, or heart failure with moderately reduced ejection fraction with the NYHA classing of 2. B is correct. So we'll walk through this just as a refresher for the staging of heart failure. So generally we start with stage A, which is patients who are at risk for heart failure, patients with pre-heart failure, symptomatic heart failure, and then progressing to advanced heart failure. Patients in stage A, these patients may have some of those risk factors previously mentioned, but they don't necessarily have current or previous signs or any signs of structural heart disease. Patients in stage B, these patients don't have current or previous symptoms, but they might have evidence of structural heart disease, increased filling pressures, or risk factors that cause them to have an increased BNP or an elevated cardiac troponin. For the purposes of this presentation, we're going to focus on those stage C patients who are symptomatic with heart failure. So they have current or previous signs or symptoms, and they also have that the structural changes. And then advanced heart failure is stage D, are patients that have heart failure symptoms that interfere with their daily life, and they come in with recurrent hospitalizations despite optimizing their therapies at home. So then the New York Heart Association or NYHA classification classifies patients with those stage C and D heart failure further based on their symptoms. So stage 1 is patients who don't have any limitation on activity. Stage 2 are comfortable at rest, but any physical activity causes them to have symptoms. Stage 3 has marked limitations on physical activity, but they're comfortable at rest. And then stage 4 is any symptoms at rest, and then any activity results in discomfort. And then finally, we'll classify heart failure based on ejection fraction. So progressing from the top to the bottom, we have heart failure with reduced ejection fraction, which is an ejection fraction less than 40%. Heart failure with improved ejection fraction is a newer term. It includes patients who previously had heart failure with reduced ejection fraction, but it's now improved to be greater than 40%. Patients with moderately reduced ejection fraction have the ejection fraction of 41 to 49%, and they may have spontaneous or provocable LV filling pressures. And then the HFpEF, or heart failure with preserved ejection fraction, includes patients with an ejection fraction greater than 50%, and the spontaneous or provocable increased filling pressures. And as I mentioned previously, we'll be focusing on HFrEF in this presentation. And then lastly, I'd just like to mention biomarkers that I use for diagnosis. The cutoffs here for the BNP and NT-proBNP are in the algorithm in the ACC/AHA guidelines for diagnosis of heart failure. And they can be useful to help diagnose or exclude heart failure, noting that these are very low thresholds for these values listed here. So what are our goals of heart failure with reduced ejection fraction management? We're trying to reduce hospitalization, decrease mortality, and improve patients' quality of life. So what do we use to do that? Typically, it's done through guideline-directed medical therapy. This includes a wide variety of interventions, but here we're going to be focused on the pharmacological pieces of that, as we are here at pharmacy. So our real pillars of this include our ACEs, ARBs, and ARNIs, beta blockers, the mineralocorticoid receptor antagonists such as spironolactone, SGLT2 inhibitors, and then hydrolizide and isosorbide dinitrate are also listed. But in this presentation, we'll focus on the 4 pillars. This is a document or a flow sheet adapted from the ACC/AHA guidance, which is our American College of Cardiology and American Heart Association. It lists those 4 pillars, and then just noting that use diuretics as needed. Those are used for symptomatic relief and volume overload, but not necessarily providing any mortality benefit or must be included in a heart failure patient. It's more titrated to their side effects. So those are the 4 agents we're going to try and optimize and add on to patients, and then you can progress through as patients do or do not respond to those therapies. But for the course of this presentation, we're going to be sticking to those 4 pillars. This slide is just listed for completeness sake. It's our recommended initial doses and target doses out of our guidelines for all of the ACEs and ARBs, ARNI, our beta blockers, SGLT2 inhibitors, and then our mineralocorticoid receptor antagonist. Noting that we generally titrate these every 1 to 2 weeks, and you don't have to reach full target dose of one agent before adding on another. Sometimes there can be limiting factors that cause you not to be able to titrate medications out of one class whereas another. So if a patient's heart rate can't tolerate a beta blocker increase, you may consider adding an ACE or an ARB and ARNI if their blood pressure can tolerate it, or if their serum creatinine and potassium can tolerate it. So this brings us to our knowledge assessment number 2. What are some of the common precipitating factors that can cause a patient to present with acute decompensated heart failure? Is it A, a myocardial infarction, B, acute infection, C, non-adherence to medication regimens, D, hypothyroidism, or E, NSAID use? Correct, it's all of them. So any one of these things can cause a patient to present with acute decompensated heart failure. So these patients may present with dyspnea, increased breathlessness, fatigue, orthopnea, cough, and weight gain. And this here just again reiterates those precipitating factors that may cause a patient to present with acute decompensated heart failure. I think sometimes it can be really easy to say a patient's here with acute decompensated heart failure, but really digging into what caused them to go into that is important for our treatment and preventing it moving forward. So our patients with acute decompensated heart failure are generally classified based on whether or not there's congestion or hypoperfusion. So congestion would be things such as pulmonary congestion, the orthopnea and dyspnea we discussed earlier, congested hepatomegaly or ascites, and hyperperfusion may be seen with cold, sweaty extremities, mental confusion, dizziness, or a narrow pulse pressure. So they're classified into warm or dry based off of those characteristics. Generally, for the purpose of this presentation, we're going to be focusing on warm and wet patients. So this brings me to my purpose for this presentation and our main clinical question. What do we do with these patients who come in on chronic GDMT for patients that are hospitalized for acute decompensated heart failure? So a provider may ask, well, these are some of the questions I have that may make me stop and think about the initiation or titration of these medications. Is it safe to do it in the inpatient setting, or should I do it in the outpatient setting? What medications do I need to prioritize to titrate? What's going to give my patient the best benefit? Is it safe to start multiple of these things at once, or should I do it in a rapid sequence? What is the minimum interval where you might increase a dose or add another medication? And should we keep a patient here in the hospital solely to increase their medication regimen or optimize as needed? I think it's always important to weigh some of the benefits and risks of these medications. So our benefits, we know they have decreased mortality, they have some renal protection, they can cause a rapid reduction in readmission risk, and they can decrease our natriuretic peptides. Some risk may include hypotension, hyperkalemia, worsening heart failure, worsening kidney failure, and ketoacidosis, noting that there's certain medications in those 4 pillar classes that we'll be discussing that impact those more than others. But it should always be a risk-benefit discussion that's had when we're titrating these medications. So what do our guidelines say? The AHA guidelines recommend that we should treat any reversible causes of acute decompensated heart failure, establish our optimal volume status, and advance all of our agents toward those target doses. They suggest that we should continue unless contraindicated, and you should initiate as soon as possible once the patient is stabilized. And with patients who have mild decreases in their renal function or asymptomatic reduction of blood pressure, they don't recommend that we routinely discontinue patients' oral GDMT. However, their recommendations are very vague. So we'll continue to go through some of the primary literature in this presentation to dive into what really made these recommendations. So for the remainder of this presentation, we're going to walk through kind of each class one by one in the literature that's there to support these recommendations and any additional considerations that I would like to add to this list. So we'll be starting first with our ARNI, which is our Entresto or sacubitril valsartan, and working our way through all of the other classes. So I'd like to start with our first trial called the Pioneer Heart Failure Trial. This was a study done by Velasquez and colleagues. It was a multi-center randomized double-blind active controlled trial that looked at the in-hospital initiation of Entresto versus enalapril among patients with acute decompensated heart failure. They included patients with ejection fraction less than 40, elevated natriuretic peptides, and a primary diagnosis of acute decompensated heart failure. They did screen patients based off of their GFR, serum potassium, and any history of angioedema, as that would contraindicate them to these medications. Their primary outcome was looking at the change in NT-proBNP, which is one of the markers of cardiac stress that's released in acute decompensated heart failure. And they looked only for a follow-up period of 4 to 8 weeks. Here you can see our baseline demographics for what these patients looked like. They were on average around 60 years old. Approximately 60% of them were on a beta blocker, 48% of them were on ACE or an ARB, and then about 10% of them were on a mineralocorticoid such as spironolactone. Their ejection fractions were on average around 24%, and their serum creatinine and potassium were within normal limits. To the right, you can see in figure 1 the changes that were seen in their NT-proBNP concentration. Your y-axis there is the week since, their x-axis there is the week since randomization, and your y-axis is that change from baseline, the percentage change. So you can see that Entresto greatly reduces that as compared to enalapril, and that difference remains constant throughout the whole 8 weeks of randomization. Table 2 at the bottom there lists just the secondary outcomes, the safety outcomes, and the difference in worsening renal function, hyperkalemia, any symptomatic hypotension, and angioedema, noting that none of these were statistically significant between 2 groups. So what did the authors conclude? They concluded that this evidence further supports the use of sacubitril valsartan in patients who are hospitalized for acute decompensated heart failure. And they did an analysis of exploratory clinical outcomes that showed that they had a lower rate of rehospitalization for heart failure in 8 weeks if the patients were taking the sacubitril valsartan as compared to enalapril. Some limitations of this study, approximately 20% of the patients discontinued therapy due to adverse events, and the follow-up only lasted 8 weeks. And then the utility of your NT-proBNP as your sole marker for heart failure improvement as a primary outcome, I think is less significant as compared to symptoms, rehospitalization, or mortality. So that brings me to our next study, looking at the implementation of rRNA in patients either early after discharge or before they're discharged, still in the hospital. This was a randomized multicenter open label study that randomized patients, again, greater than 18 years old, who were here for acute decompensated heart failure with the NYHA class 2 to 4, and they had to have a blood pressure greater than 100 milligrams of mercury. They were excluded again if they had an elevated potassium, had symptomatic hypotension, or if they had a blood pressure greater than 180, or systolic blood pressure, excuse me, greater than 180. So these patients, again, the beta blocker use is about 43 versus 47% in these patients. Surprisingly, about 35% of them were already on a mineralocorticoid, and only about 25% of them in both groups were not on either an ACE or an ARB. Their ejection fractions were on average 29%. And you can see that about half of the population in both groups had a prior hospitalization for heart failure. In figure 1, this is showing us the percent of patients who were able to get to target dose of that 97 to 103 milligrams at week 10, and how many of them continued to keep it. And then on the bottom here, you can see the most common adverse events that cause patients to permanently discontinue, Entresto during that 10-week period, noting that there's no statistical difference between the patients who are starting on an inpatient or outpatient. So the authors concluded that the initiation of this Entresto is safe in patients hospitalized for acute decompensated heart failure and is feasible with approximately half of the patients getting to target dose within 10 weeks. And then they concluded that there was no difference in those adverse events. Some limitations: this was an open label study that allowed patients in the pre-discharge group to receive treatment late in their hospitalization. So if they just received a dose as they were being discharged, that was considered pre-discharge versus a patient who might have picked up the prescription as they left the hospital. So I don't know that it's very clinically significant as to what time of day a patient received the dose, and they didn't quantify when that was. And then another limitation would be we monitor patients much more closely when we have them here in the hospital, because we can get the labs we want and see the vitals that we want objectively, whereas in the outpatient setting, you're not going to have as close of that follow-up. So the adverse events may look different just because we're not looking for them as frequently in the outpatient setting. So what should we do with an ARNI for patients who are here and admitted for acute decompensated heart failure? I think our best bet is to identify patients with HFrEF who have already tolerated an ACE or an ARB. And if their insurance coverage allows, trying to transition them to an ARNI, making sure we always keep in mind our renal function, the potential for hyperkalemia, any type of volume status that might cause some hypotension, ensuring patients have the 36-hour washout from an ACE inhibitor, and then always making sure that these medications are accessible to our patients, because if we prescribe a medication and they can't receive it, we lose our benefit there. Next, we'll walk through ACEs and ARBs and the literature that's out there to support them in acute decompensated heart failure. So this is a retrospective chart review of the Get With The Guidelines Heart Failure Registry that is only using linked to Medicare data performed by Gilstrap and colleagues. They just reviewed patient records for patients with a heart failure diagnosis who were eligible for an ACE and ARB, who were either started, continued, discontinued, or not started on these therapies during their hospital admission. The patients were excluded if they did not have, or if they had a left ventricle ejection fraction greater than 40%, they had any contraindication to therapy, they were started on an ionotrope, or they were discharged to hospice or comfort care. The primary outcome was the difference in all-cause mortality at 30 days between patients who either continued or discontinued ACE/ARBs at discharge. So here we can see our baseline demographics across all of those pre-slated groups for patients who had their varying changes in ACEs and ARBs therapies, noting that approximately 40% of these patients had a history of diabetes, and approximately 75 to 80% of these patients had a history of hypertension. Figure 1 here is the estimates for 1-year mortality, walking through days after discharge for the year follow-up that was completed, noting that the black line is for patients who were discontinued on an ACE or an ARB. The red line is those who did not start. The blue line is those who started, and the green are those who continued. So you can see the effect size there from day 0 expanding all the way out through the end of the year. The difference in patients who were discontinued or not started did not have the same benefit as those who were started or continued during their stay. And then to the right, figure 2 estimates our 1-year readmission. While there's still an effect size between the patients who were discontinued or not started on these ACEs and ARBs, there is still a difference between that and our patients who were started or continued. This is the same information with a proportional hazard ratio that compares those readmissions and mortality between groups, noting that for the patients who were discontinued or not started, again, is statistically significant versus those who were continued. This goes across for the 30-day mortality and readmission, 90-day mortality and readmission, and then 1-year mortality and readmission. And then finally, I'd just like to mention the labs and vitals from admission and discharge for these patients who either continued or started, noting that blood pressure and the NT-proBNP levels appear to downtrend from admission to discharge. Serum creatinine is relatively unchanged, but the baseline serum creatinine in patients who had their ACE or ARB discontinued or not started were higher than those who were continued or started on these therapies. So what did the authors conclude about this study? They concluded that the initiation or continuation at time of discharge for admission was associated with that lower 30, 90, and 1-year mortality rates. And they had lower readmission rates as well compared to those who discontinued or did not stop therapy. Some limitations, being a retrospective chart review, we just have the information that the chart is able to provide. So we may not have captured full clinical pictures if documentation does not allow. Excuse me. And we don't have the ability to track patient adherence for prescribed medications after they leave. So we're only able to pull claims from the hospital stay. So what should we do with our ACEs and ARBs for patients with acute decompensated heart failure? I think that it should be started or continued during hospitalization whenever possible, keeping in mind renal function, volume status, the potential for hyperkalemia and other medications that can impact that. And then again, switching to an ARNI if a patient can tolerate hemodynamically, meaning their blood pressure can handle it. These medications are fairly accessible to our patients in the outpatient setting. And so it's always, I think, a good thing to keep in the back of our mind for patients who aren't on it, but could be optimized with the addition of one of these medications. Next, we're going to be talking through beta blockers and their role in acute decompensated heart failure, which brings us to our next knowledge assessment. Which of the following scenarios would be an appropriate situation to withdraw chronic beta blocker therapy in patients admitted for acute decompensated heart failure? Is it A, when their heart rate drops below 60 beats per minute? B, when a patient is requiring IV dobutamine? C, when their systolic blood pressure drops below 100? D, all of the above, or E, none of the above? So B, I think, is what we have the most literature to support. And we'll go through some studies here moving forward. So there's a little bit more literature to support or discussing the use of beta blockers in acute decompensated heart failure. So I've condensed 3 studies here, and then we'll have some additional ones afterwards. Starting with the first one, which is beta blocker use and outcomes among hospitalized patients. This was a study that aimed to determine the effect of beta blocker therapy on patients who are hospitalized with heart failure who were enrolled in the ESCAPE trial. They evaluated 268 patients who were on a beta blocker before admission and determined that they had a shorter length of stay and a lower 6-month mortality rate. Patients who had beta blockers continued also had that lower 180-day rehospitalization and death rate. And so their take-home message was that the continuation of a beta blocker led to lower mortality and rehospitalization subsequent to discharge. The next study is the results from the COMET trial, like a secondary analysis of it, that looked at 752 patients out of the slightly over 3,000 patients who had a non-fatal heart failure hospitalization while on beta blocker therapy, and found that 8% had the beta blocker withdrawal, 22% had a dose reduction, and 70% were maintained on the same dose. They found that the 1 and 2 year cumulative mortality rates were higher for patients who had the beta blocker withdrawn compared to those who were maintained on the same dose, and concluded that heart failure hospitalizations have a high associated mortality, and the risk of death is higher in those who discontinue a beta blocker or have their dose reduced, but did not go into the reasons in which the doses were reduced. And then finally, the last study summarized here looks at beta blocker continuation or interruption for patients who are hospitalized with acute decompensated heart failure. This included 147 patients who were followed just to demonstrate non-inferiority of pursuing a beta blocker when as compared with stopping beta blocker therapy during admission. So during the hospitalization, the clinical features of heart failure, such as some patient-reported symptoms, heart rate, and blood pressure, similarly decreased in both groups. And the authors concluded that chronic beta blocker therapy during acute decompensation in patients with systolic heart failure does not delay clinical improvement when dobutamine is not required. So they did exclude all of the patients who were requiring IV dobutamine from their study. Next, we're going to look at a review done by Fonerau and colleagues that looked at the influence of beta blocker continuation or withdrawal in patients hospitalized with heart failure, which is like a subgroup of the optimized heart failure program. It's a prospective review or a prospective study done of patients enrolled in this optimized heart failure program. That's a hospital-based registry and process of case improvement program designed to enhance quality of care for heart failure patients. Patients were included if they were hospitalized for new or worsening heart failure, or if they had significant heart failure symptoms that developed during their hospitalization. They had to have an ejection fraction documented less than 40% and moderate to severe systolic dysfunction, and then excluded if they had an allergy listed to a beta blocker, a second or third degree heart block, any symptomatic bradycardia, or reactive heart failure disease. Their primary outcome during the first 60 to 90 days is just basically trying to see if the outcomes are different for mortality and readmission. Here you can see the baseline demographics, again, stratified based off the patients who had therapy continued, new therapy started, therapy withdrawn, or therapy not prescribed. Noting that there are a few that are statistically significant, including the age, the history of coronary artery disease, hypertension, hyperlipidemia, and then the ejection fraction was statistically significant between the groups. So what did they find? They found that in patients who were continued on beta blocker therapy or versus the patients who were eligible were not treated, they found that that was statistically significant, as well as patients who were newly started on beta blocker therapy versus those who were not treated. So patients who were continued or newly started had mortality benefit over those who were not started but eligible. And then they also found that patients who were withdrawn from beta blocker therapy versus continued also had increased mortality that was statistically significant. They also found that in terms of mortality and rehospitalization, patients who were continued or newly started were also had better outcomes than those who were not treated. Here we have a figure that is the Kaplan-Meier survival curves for post-discharge survival. That's again stratified by the groups of patients who received beta blockers that were newly started in yellow, continued in blue, not treated in green, and then withdrawn in red. So as on our y-axis, you can see, or I'm sorry, x-axis, you can see we progress against days since discharge from 0 to 90-day follow-up, and then the increasing mortality rate there. Again, noting that the patients who were withdrawn and not treated had increased mortality as opposed to those who were continued or newly started. So what did our authors find? They found that the therapy should be continued or started in all eligible patients. In the absence of their pre-specified exclusion criteria, the decision to stop a beta blocker should be based on clinical judgment, and that the abrupt cessation of beta blockers has been associated with ischemia, hypertension, ventricular arrhythmias, and myocardial infarctions and should be avoided if at all possible. Some limitations of this study: it's a retrospective review of patients in a heart failure program with the follow-up only lasting for 90 days after discharge. So I'm not sure we would have caught all of the events that happen in a patient's lifetime, as we only studied the 90 days afterwards. And then there was not data collected for the reasons that the beta blockers were discontinued or withdrawn during hospitalization, so the authors could not speak to that. So what should we do with beta blockers in the acute decompensated heart failure setting? It's been consistently seen that the continuation of beta blockers has been associated with improved outcomes, and withdrawal of beta blockers have been associated with higher risk-adjusted mortality. You could consider removing or withdrawing beta blocker therapy in patients who are recently implemented on beta blocker therapy, and their current presentation can be attributed to that new start of a medication. They're in cardiogenic shock requiring vasopressors or inotropes. They have advanced AV block in the absence of a pacemaker, or if they have marked fluid overload with a marginal to low cardiac output. I've included here a schematic that kind of works through in a very basic term what cardiogenic shock looks like, starting from the bottom, which is stage A, patients at risk, all the way to the top, which is stage E, extremists, which is patients who are already in circulatory collapse. They're requiring ECMO, ongoing CPR, or having frequent cardiac arrest. So just trying to keep in mind patients who are admitted with acute decompensated heart failure, they're having an exacerbation. If we're starting to think that they may have cardiogenic shock, how high is our risk for that in this moment? And do we need to be addressing the beta blocker therapy? Next, we'll move on to SGLT2 inhibitors and their role in acute decompensated heart failure. Which brings me to our next knowledge assessment question. Which of the following patient characteristics would make a patient most likely to benefit from the early initiation of an SGLT2 inhibitor during their hospitalization for acute decompensated heart failure? Is it A, uncontrolled diabetes with an A1C of 11, B, the ongoing need for diuretic escalation, C, an acute kidney injury with a serum creatinine of 3.2 and an eGFR of 19, D, A and B, or E, none of the above? So I would argue that it's B, and we'll walk through what that might look like and some stipulations to this. Noting that in a patient with uncontrolled diabetes, which somebody might think would be another patient that might benefit, when a patient has an A1C of 11, they're going to be spilling a lot of glucose into their urine, and the mechanism of action for an SGLT2 and all that glucose that's in their blood that needs to be filtered can greatly increase their risk of side effects such as urinary tract infections. So it's probably a better idea to get their diabetes somewhat controlled so they're not spilling as much, or they don't have the potential to lose as much glucose in their urine and cause those side effects. So these are some of the studies that have addressed SGLT2 use in acute decompensated heart failure. And we'll work our way from left to right. The first one is the IMPA response acute heart failure study by Damon and colleagues. They had patients who either had or did not have type 2 diabetes, who are hospitalized for acute decompensated heart failure, who had dyspnea at rest, signs of congestion, elevated BNP levels, and were treated with loop diuretics at admission. Notably, approximately 38% of these patients had type 2 diabetes in the empagliflozin group. They assigned patients to receive either empagliflozin at 10 milligrams per day or placebo for 30 days, and they initiated it within 24 hours of presentation while the patient was still on IV diuretics. They found that the use of empagliflozin significantly reduced our composite outcome of worsening heart failure, rehospitalization for heart failure, or death at 60 days compared to a placebo. The next study is the Soloist trial that was performed by Bott and colleagues. They evaluated patients with type 2 diabetes who had signs and symptoms of acute decompensated heart failure, who received IV diuretics, and who had an elevated BNP. They randomized patients to receive sotagliflozin or placebo for a median of 9 months, initiated before or shortly after discharge. And they found that the addition of sotagliflozin led to a 22% reduction of composite cardiovascular death and hospitalizations or urgent care visits, and improved their quality of life compared to placebo, noting that they used the Kansas City Cardiomyopathy Questionnaire to evaluate quality of life. And this includes symptoms and patients' impact on life over the course of 2 weeks. Next, we'll go to the IMPAG-HF trial. This was done by Schultz and colleagues, and they randomized patients with acute decompensated heart failure, again with elevated BNP levels, within 12 hours of their hospitalization for the acute decompensated heart failure. They gave patients empagliflozin at 25 milligrams per day or placebo for 5 days. That was started within this 12 hours of admission, and found that empagliflozin led to a 25% increase in cumulative urine output over 5 days compared to placebo without any change in patient's renal function. And then finally, the Impulse trial. This was a trial done by Vors and colleagues that seek to evaluate if the in-hospital initiation of SGLT2 improved outcomes for heart failure. They included patients with any ejection fraction, noting that approximately 67% of them had that ejection fraction less than 40, and approximately 50% of them had type 2 diabetes in the empagliflozin group. They randomized patients to receive empagliflozin at 10 milligrams a day or placebo for 90 days, started a median of 3 days after hospital admission, however, not addressing the patient's full length of stay. They found that empagliflozin led to an early clinical benefit defined by their composite that had all-cause mortality, time to heart failure events, and improved quality of life. And then lastly, there's a new trial that's in the process of coming out. It's the Dictate HF trial. It's a prospective multi-center open label randomized trial that evaluated dapagliflozin at 10 milligrams a day versus standard of care until day 5 or hospital discharge. Noting that both of the patients both received protocolized diuretics and insulin therapies. The patients did have to have diabetes. They had to have an eGFR of greater than 30. And their primary outcome was diuretic response expressed as a cumulative change in weight per their cumulative loop diuretic dose that was administered. This was presented at the ESC Congress in 2023. The data has not actually been released, but the data supported early initiation of dapagliflozin in acute heart failure to safely facilitate decongestion and GDMT optimization. So what should we think about when we're thinking about starting an SGLT2 here in acute decompensated heart failure? I think it's a good option if you have a patient who needs help in their decongestion of hypervolemic acute heart failure or acutely decompensated heart failure, making sure we keep in mind their volume status. If they have acute kidney injury, is their creatinine or their GFR high enough where they're able to do it? Do they have a diet? Do they have adequate intake? Have they ever had a history of diabetic ketoacidosis, given the risk of euglycemic decay in these patients? Are they on other diuretics and RAS inhibitors? And then do they have comorbid states such as atherosclerotic cardiovascular disease that may benefit? This is a proposed algorithm that I reproduced from Baldwin et al. And colleagues that kind of walks through some things you might think about when you're trying to decide if you should start an SGLT2 inhibitor while a patient's admitted with acute decompensated heart failure. Again, just emphasizing that we need to be addressing patients' clinical status, their volume status, their renal function. Were they on an SGLT2 inhibitor for admission? If they were, you can continue it. If they're not, it gives recommendations here of the doses you would start, making sure that we have appropriate follow-up. I'd add to this just to be sure that we're monitoring for patients' PO intake and their overall diet status, just again for that risk of euglycemic decay. And then finally, we'll look at the use of mineralocorticoid receptor antagonist in acute decompensated heart failure. Here, I've again summarized some of the literature that's used to evaluate the use of spironolactone and eplerenone in acute decompensated heart failure, starting with an article by Bistola and colleagues. These patients had ejection fractions that was around 35% in the patients who were treated with spironolactone versus 38% in those who were not. And it's a post hoc analysis of the Alarm HF registry. And they found that the patients who received this spironolactone during admission had reduced in-hospital mortality, but did not evaluate it for patients once they left. For the second trial listed here, the effective spironolactone on 30-day death and heart failure rehospitalization. This is looking at the coach trial information like a secondary analysis. Again, these patients had the reduced ejection fractions, and they were randomized into usual care, basic support, and intensive support, noting that these three categories, do not actually have anything to do with the medications they received, but it's more with the contact with providers and nursing and follow-up that they had. So the study was not originally used to evaluate the use of medications. This is just a post hoc analysis or secondary analysis, that found that the continuation of spironolactone had fewer 30-day mortality and heart failure rehospitalizations. But the original goal of this trial was not to evaluate medication use. So I would interpret that with caution. And then lastly, we have the Athena HF trial that evaluated the use of low dose versus high dose spironolactone versus placebo at 96 hours. They found that a high dose of spironolactone was not associated with any improved outcomes as compared with usual care. So that study just supports that if you're going to give a patient spironolactone, you don't necessarily have to use the higher dose in order to receive the outcomes you're looking for. This next slide is just more of the data that comes from the first trial I mentioned there by Bastola and colleagues that looked at the patients who received the spironolactone versus those who did not, and looking at the difference between groups and the other medications that they received. Noting that this trial was done again before we had the ARNI, our sacubitril valsartan, and then seeing the differences there in the medications patients received. Again, noting that the patients who had spironolactone might have been more likely to also receive some of the other medications. So what should we do with our spironolactone and eplerenone for patients admitted with acute decompensated heart failure? I think if you have a patient who's really hemodynamically unstable and you're looking to add an agent and their renal function and potassium can handle it, it could be a really good option because we only require those lower doses of the 12.5 to 25 milligrams to make this a benefit for patients. Making sure we keep in mind, again, volume status, our potential benefit in other comorbid states, hyperkalemia, and renal function. So now I'm just going to kind of summarize what should we do in a more concise way, looking back through all the literature that we've processed through our CE today. So on the left here, we have our beta blockers. We should continue GDMT in patients who are hemodynamically stable and are doing well. You might change it in a patient who has or you might start it, in a patient who's stable and has a clinically euvolemic status, their renal function's okay. Sorry, not the renal function, their heart rate is okay. Being sure to counsel on any side effects and make sure we have the follow-up appropriately scheduled to continue to titrate to our target doses. You might stop it in a patient who's having borderline perfusion, signs of cardiogenic shock, or is requiring a vasopressor or ionotrope requirement. Our ACEs and ARBs and ARNIs are generally well tolerated. I would start these in a patient who has good stable renal function, they're euvolemic, and they don't have any history of angioedema. Again, making sure we optimize patients from an ACE or an ARB to an ARNI whenever we can. Ensuring we have that 36-hour washout for patients who've had an ACE inhibitor and are transitioning to the ARNI. Again, counseling on side effects. I might stop this in a patient who's, again, hemodynamically not can't tolerate it. It's having hyperkalemia, substantial renal dysfunction, or angioedema. For our SGLT2 inhibitors, they're safe and well tolerated in most of our patients, making sure, again, we have stable renal function and adequate PO intake due to that risk of DKA. We've counseled patients on the benefits that they can have regardless, and requires close follow-up to ensure that they're tolerating them well at home. You might stop this in a patient who's having hypotension, they're dehydrated, they're having a dehydrating illness, they have poor oral intake or substantial renal dysfunction. And then lastly, our mineralocorticoids such as spironolactone. These are, again, well tolerated. I might choose this in a patient first if they're having hemodynamic instability, or we suspect they might be hypotensive when they go home because the lower doses can provide that benefit. They require close follow-up for their renal dysfunction and hyperkalemia. So lastly, I'd just like to mention transitional care plans because I think it can be really easy to take really great care of patients here, but if we don't have them set up for success as they leave and transition back out into their own lives, we may be doing them a disservice in titrating medications appropriately. So when you're having a patient you're discharging who just had an acute decompensated heart failure hospitalization, make sure you have a plan for resuming anything that's held in the hospital and communicating that appropriately with the patient. You have plans for initiating new medications, so that may be given in handoff in your discharge paperwork to whatever follow-up appointment they're going to have. Plans to titrate medications to goal doses, noting that you don't have to titrate one medication all the way to goal before starting another one. And then making sure we have our laboratories check for renal function, hyperkalemia, and others as needed. So this leads me to our last assessment question of today. We have a patient MJ who's a 66-year-old male who's nearing discharge after being hospitalized for acute decompensated heart failure. Which of the following items would be included on your discharge plan for follow-up with a primary care provider? Is it their renal function, B, symptom improvement, C, tolerance of current medications, D, tentative plans for stepwise addition and optimization, or E, vital signs? It's gonna be all of them, yes. And that concludes my presentation. What questions do you have for me? Yeah.
More recent studies that have come out that compare ARCs and RNs. So knowing this and knowing this, no difference in mortality movements between ARC and RNs, is there ever really a time to use a more expensive medication in the hospital?
I would have to review that literature, but if the literature supports that they're equivalent, I would say that no, in this population, if they don't have another indication for it. Yeah.
The difference between the 10 and 25 milligram of the hypochlorite. This patient population, should we be pushing to 25?
Yeah, I was gonna say, so the question was about the dosing of empagliflozin in this setting. So there's two doses that were mentioned on the slide. One of the studies included patients who all had diabetes. So the dose we'd be using for patients who have diabetes and are gonna be on empagliflozin is gonna be the 25 milligrams, whereas the heart failure dose is the 10 milligrams. So in the absence of diabetes, I don't know of a time when we would push it to the 25 milligram, but I could go back and review that. Any other questions for me this afternoon? Thank you for coming. Oh, wait, here's your code. I'm sorry. Here's your code to be able to get the CE today.